work from disease modeling or health science modeling in general? Some of you were saying that they have worked on epidemic models, for example. Anyone? No one? No one have used any data set before?
Breast cancer data set.
Breast cancer, so oncology data. What does that data include?
So that included healthy females versus there was one controlled sample and treatment sample, and through treatment how much percentage of that portion has tumor.
Oh, so it was within the body.
Yeah.
Within the body. So that's very important. What he's saying is in-host biomarkers or testing data, basically, for example. In this case, he's talking about size of the tumor, right? Was that the one?
Yes, sir, but it was not from the medical. It was one of the internships through a private company during the COVID time.
But okay, fine. That's it could be coming from anywhere. But the point is, was it a real data or was it a hypothetical data?
The real data from Chennai-based hospital.
But data obtained from test instrument like MRI.
They were doing image segmentation and then
image. So images are like MRIs, X-rays. These are images, right? So MRI is where probably a CAT scan or something like that, from where his data was. So basically, it was showing the size of the tumor over different time points. That's it. So that data is very useful. It tells you the growth rate of tumor over time, for example, if you have a tumor. Who else has used any kind of real data? Anyone? No one has used the real data? Okay, who has used the unreal data?
I used data for heart disease,
Okay.
but I don't know real data is critical.
But what does that data contain? I can help you with that.
The data has age, BP,
Age.
sir.
Age.
Blood pressure, sugars,
Okay. So,
exercise of stroke, etc. 14 diagnostics that I have.
okay. So there were. So what is saying? Age. Age is what type of data? It's a demographic data, right? Gender, age, locations. Those things fall into demographic aspects. Then he's talking about clinical data also. What was that clinical variable?
Blood pressure,
Blood pressure. So those are biomarkers. Blood pressure, sugar level, and these were cross-sectional or at one time point or at multiple time points for a same person.
multiple times.
For the same person.
Different persons.
Right, of course. The reading might happen at different point, but for one person it was single time.
Yes, sir.
Okay. So it was not, it is called longitudinal, it was not longitudinal data, it was a cross-sectional data at single time point, right? So that's something to note here, okay, which is fine. So again, this is in-host within the body, right? Within one person, that is what he's talking about. But if you collect it over many, and what was the outcome? What was cardiology you were saying? So
Heart disease, sir.
heart disease, which heart disease?
Yes.
So the outcome was whether the person has a heart disease or not.
Yes, sir.
Something like
Using some lasting recognition.
Yeah, so basically he was using multiple demographic and clinical parameters and predicting the chances of this person to have a particular heart disease.
Yes, sir.
What type of heart disease was this?
Common, sir.
Well, there are very specific there are different types of heart disease, by the way.
I am mentioning as a heart disease only, sir.
Okay, fine. So any kind of heart ailment, they were clubbing into one disease, and that was the, so it was a regression model, basically. That's a prediction for regression.
Yes or no type?
Say it again?
Yes or no type?
Yes and no type. So there was data, this data was obtained from?
Government website. One of the.
So it was coming from hospital, it seems like. It will be.
By BSc, sir.
Huh?
BSc project, sir.
BSc project, okay. Anyone else? I heard many of you were working on epidemic models. Have never seen the data? Never? Okay. So, okay. Okay, thank you. So, why don't we do one thing very quickly? Look for IHME online. Look for IHME online and see what is it. IHME, very important website for you all. IHME. It's in Washington, Seattle. Thank you. Anyone able to find what is IHME stands for? Correct. Can you say it loud? Can you say it loud?
Institute for Health Metrics and Evaluation.
Institute for Health Metrics and Evaluation. This is a department in University of Washington in Seattle, and they are collecting large amount of data from all over the world. And this is a good source for collecting socio-economic variables and clean health variables also. So that's where you can look for if you are interested in something for you. And they are global, not only for US, they are doing it for globally. Okay, this is also a CTIS. They did a survey. You know, a lot of data is collected through surveys by asking people, right? And they did surveys, large scale survey with Facebook. And Facebook, you know, what is Facebook? Meta, basically, right? So the private university, Carnegie Mellon is a private university. Carnegie Mellon is in New York, and so they both had this data called a C-test, and it's measured about behaviors, attitude, economic impacts, these type of work. IHME on the other hand, you looked at IHME. What is IHME containing? Did you look at it? IHME contains what?
Global health data.
Right, so disease burden. How is disease changing over time for multiple diseases? It is not only collecting that, it is also collecting socioeconomic patterns. They are building models also and extracting more data. So my suggestion is to browse this website IHME and find out there's a huge amount of data that you can use for your work. And these are authentic data. These are very, very good data. If you can find for your, again, it is a huge set of data, so you have to look for precisely what you are looking for, but this is the one of the source. Okay, so why data matters in epidemic model? Because without data, all your study is theoretical, right? The implications from it is for understanding, but not practically using it in a practical field, right? So that is one thing. So you need a data, but poor data is also a problem because it might give you a misleading prediction. Now, how do you handle poor data? Is through the estimation methods. There are different estimation methods that handle the uncertainty. Remember that yesterday I was talking about there are different sources of uncertainty, right? So those are captured on this estimation method that we will talk about in the late afternoon. Okay, so that is poor. How to handle poor data is what we will be talking later. So understand. So what is our goal today? Is to what is data we need, why it matters to us, and how to use it responsibly. I mean, not like as a black box. Oh, this is my data and I use it. I need to understand how is it collected, because that will tell me the uncertainty. That will tell me which method of estimation to use. Okay, so not only taking the data, but the process in which someone else collected it and put it somewhere, we need to understand that. So from Indian context, COVID-19 second wave, you remember COVID-19? I don't know if you guys remember it. COVID-19 second, we were thinking the outbreak was over after first outbreak. And all of a sudden it came back. Why? Because there were many reasons, and I don't want to be political here, but the data was very much delayed or hidden. And that was the reason. Modelers didn't know what they were using bad data. I mean, they couldn't even guess because it was so much hidden. They couldn't even guess what could be the uncertainty there. You have to guess it intelligently about uncertainty. So if you cannot guess, it is so much hidden, then you are blank in that. So how delayed or underreporting was the big issues, and delaying was the another issues. Two led to the misled planning in COVID-19, and then second wave came crashing, and we were unprepared. Our hospitals were not having resources. We didn't have enough bed. We didn't have oxygen cylinders. It's not that we have not tackled it before. In earlier years, we have tackled it in a large scale, but that time we couldn't because the modelers they were predicting a small number of cases because they were using this delayed and underreported data. So accurate district level, critical for accurate district level data. Actually, we use it at a fine level. We want to go at a very, very small level. So what is that? So there is a neighborhood. Neighborhood results in blocks. Blocks. This is a standard way the data is collected. After blocks, what is after blocks? Say it again?
Subdivisions.
Subdivisions. Exactly, subdivision. Very nice. And after subdivisions, district. After subdivision is district. And after district, region. Regions. And after regions, state. And state goes to central. This is how the data is gone upward and what you see in the surveillances. Now, anywhere the problem occurs, you get an incomplete data on the top, right? If you are interested in mapping the nation policy, if you are interested in local policy, then you have to use that level of data, basically. Okay, and how is it collected at the very neighborhood level? How is it collected? Anyone has an idea? How did you know some reasons for it?
Sir, my father is administrative service. So
In health department?
No.
Huh. In general.
in the-
Okay. So it is collected through ASHA workers. You know ASHA workers?
Yes.
They are at a ground level, checking every door to door. That's how. That's one mechanism of collection. And the second mechanism of collection is through the people reporting to the local hospitals. That's another way of reporting. But ASHA workers make sure that reporting happens at a very low level, because many poor people thinks, oh, I will be recovered myself. I don't have to go into the medical facility because it costs money sometimes, or the time that they can use it for earning money, right? So the ASHA workers goes door to door almost every day, and that's how they collect the data. They have the survey forms, and they collect the data. So basically, accurate at that level of information is very key. And so ASHA workers are very good data analytics. They are trained in data analytics also. Do you know that? They are trained how to collect good data, not doing analysis, but to how to collect it a good data, right? So that's the very important aspect. Okay, so also there are phases of an outbreak. So what are the phases? You see there is a early detection phase where there are very few cases of it. Patient 0 starts from here. Then there is an early response phase, and this is an exponential phase. The early response phase, around middle or end of the early response, is when the intervention is, people start to realize that there is an outbreak. I mean, government should be able to realize it much earlier because they are using ASHA workers all the time. It's not non-stop work, right? So they know when the first case or second case have started to come. But that happens around this time, a middle of an early response. And then it peaks, and then the process, this red portion is an intervention. A different type of interventions government tries to implement, right? When I say government, it could be local government, it could be state government, it could be much higher central government. And then it is a post-intervention that you want to plan it, that it doesn't occur in future, and we are prepared. So there is other things that happen. So these are the 4 distinct phases And what we do when we calculate transmission coefficient, you see, we never have the whole data. We never, if there is a whole data, then there is no use of modular. The outbreak has already passed. Why do you teach a modular? Do you understand my point? Modular role comes right here when they start to realize, well, there is an outbreak and what should we do? So there is initial outbreak, right? There is initial, that exponential phase that yesterday we were doing. We use that data to estimate the production number, estimate beta, and that's how we track the disease. Okay. So this is important phases to understand. And this is very important. Focus of public health responses. How do you respond in different phase is different, very different. And when I say public health response, the response only comes when the modeling exercise is done behind the scene. The public health officers go and take the results from the modelers and take the action. For example, here in this period, the risk assessment. What is the risk that truly it will go and it will become peak or it will die out quickly? We don't know, right? So there is a risk assessment models that decides on whether the disease will be truly a large number of cases and how we will handle it. Here, different type of interventions, whether it is going door to door and identifying patients, or basically quarantine, for example, isolations, vaccine, different intervention starts to play its role here. And finally, this is where the capacity building. So if this outbreak occurs again, or there could be, so what happens typically is when it goes down, it is considered that it will start again. So you have to plan it so that it doesn't pick it up also. So there is things that it is typically the resources when the outbreak is towards this end. Government says, oh, I have other important things to focus on and move this money from here to there to the different sources. It is not always infinite amount of money, right? You understand my point? So the interventions are very good in this important peak during the peak time. But once it crosses a threshold limit, the interventions also decline. The efforts of interventions also decline. Okay, so you have seen these 4 different stages that we were there are, I don't know if you can read at the back. Can you read at the back? Or it is very small. Okay, so what it is listing is the type of the data that we use. Type of the data which we use at the different phases. That is what it is listing. So first one it is listing is, it's an early stage, pre-stage, right here. Early stage, you don't have much information about the disease. What data you will use? 1-2 cases has occurred, so what you will go is the historical. Any other outbreak in the history has occurred or not. So you use the literature a lot in this phase, right? And you use the mobility data. What is mobility data?
Travel data.
Right, so travel data. And where is the travel data come from?
From airport authority.
Okay, from airports, from the buses, right?
Then
But-
railways.
Huh?
Railways.
Railways, that is the data we use, which is called a mobility data. But that's not the only data. What other data? This is, you are talking about long distance movement. What about short distance movement? Within cities. Where is that data will come from?
Traffic department.
Say it again?
Traffic department.
Traffic
Traffic department.
Traffic department. Traffic department. Traffic department has some data like that? I doubt it. Yeah, they might have it, but there may not be anything on the website that you can find and use it.
In schools transfer certificate.
Say it again?
In schools transfer certificate.
Okay, so that would be for the kids only, not for the parents or anything like older adults or families for whom there are no kids, right? So you will not know about them. Yeah. So she's talking about school transfers, right? So that, but also that the data is difficult for, they don't disclose the data. That is a private data basically.
We can get to registry like tenants who came in another city like that.
If I tell you right now, you will say, oh yeah. But somehow you guys are not giving me the answer that I am looking for. What is the local data? Yeah, so it is not captured properly, but it is captured by one mechanism very well.
ID cards like
Voter
voter
ID.
ID,
Voter
Aadhaar,
For voter ID, how will you track voter?
address.
Well, that is if you are physically moving, and that doesn't happen on a daily basis, right? It might happen in years, right? No, we are going to office, we are going to school, we are going to, various places, market, shopping, right? Where is that? How will you get that data?
Through Google.
There you go. Not necessarily Google, but apps. When you have a cell phone, there are thousands of apps that you are using. Some of them are collecting. There are companies that are just collecting your movement. You would be surprised that they know everything what you do. It is not easy. So they are capturing that movement, and that is getting to a centralized place. They pay lots of money to these cell phone companies and buy this apps tracking data. It is called as location-based services data. Location-based services data. So it's literally at every instant it is tracking. Even if you have one app open, it will know your behavior. You understand my point? And you have so many apps on your cell phone. So this is the data that we are using in epidemics also. And we need to buy it. It is not freely available. We need to buy it. Also we use CCTV cameras nowadays. This is very common nowadays. Almost and these are, you see, how CCTV camera work. CCTV camera, even though it is at NIT, but it is managed by some big company. And so this data is being stored in the centralized location of that big company, and they are getting it from multiple CCTV cameras, not only at NIT, but other institutions, other organizations as well. So they are using that data even to track now, and although these are not supposed to be so clear enough, but it is still happening. There are ways, for example, in my setting, I have closed down tracking of by the apps, right? But even if I go and do some searches from some location, some other website can track me. It is not necessarily the apps, but it is me searching something can track me also where I am and what I am looking for. But anyway, so this is one thing which is very important. So mobility data comes from there. So long-term data, air travel, buses, train. Short duration data is location-based services, CCTV camera data, basically. Then you are at the middle age, then you have the epidemic count. Now you have an epidemic count. So now you can use an epidemic count and use an exponential growth data to fit the model. Does that make sense? Okay. And then finally, once this is there, then what data you use after that? After the peak has come down. Peak comes down. Why is peak comes down? Why is peak come down? I mean, why is the cases come down? Why not it keep on rising? Because of the interventions, but not only that. Not only that.
Either everybody like most of
Virus
the population may be getting
Right. They are not getting enough susceptibles, right, in the population, because we are talking about, let's say, an outbreak in a city, right? City has a limited population. So once it reaches a threshold, there is not enough susceptibles to keep burning, right? But also intervention pushes it in a way. What does intervention doing? What is intervention doing?
Part-time.
No, but what is the intervention doing in the dynamic? Huh?
Reducing the contact.
Reducing the contact. In other words, it is reducing the pool of susceptibles. Contact reducing means it is, even though they are susceptible, but somehow they are not coming in contact due to the interventions. So it is still reducing the susceptibles, the interventions are taking it, right? And then basically, once this thing happens, so then what data is now available? Additional data is now available. See, these are step-by-step data is coming into picture, and you have to use whatever the data is available in the modeling sense. Initially, you don't have the count data, for example. You understand? So now when you are here, what data is available? That means the peak has reached, that means you have started intervening it due to some interventions, and they are working out, and therefore it is going down. So you now have an intervention data. That this much effort I have made, and it has controlled that many number of cases. Right? So now you have additional data is an intervention data. Right? Then what data happens? You get after that? Huh? Well, recovery data comes from where?
After the intervention.
No, but what is the source of the data recovery?
Hospital.
Hospitals. Exactly. The people are getting discharged from the hospitals. Right? So now you are getting an hospital data. Now this is an additional information that goes in the model. That's an additional information now goes in the model. So you see, slowly and slowly you are building more information in the model, and you are getting better and better estimates of the model. Right? Initially you have large uncertainty in the parameters. And as you approach towards later part of an outbreak, your uncertainty reduces. Does that make sense? And that is how we model slowly and slowly. It is not about the complex model, it's about complexity of the incorporation of the data. Do you understand? Because it's a different types of data, different units, different way it is collected. So you have to match these data, and it is not collected for the purpose of you doing an epidemic model. It's a different purpose. Hospital data is for hospital purpose, not for the epidemic models. Now, so you have to convert it into the way that you can capture it for the parameters and the variables in your model, the definition that you have given. Does that make sense? So this is very, very difficult task, and people spend their whole life doing these things, basically. And then what happens is you start using mortality data also. Mortality data are used. Where is the mortality data come from? From government sources, yes. Yes, but that is complete data? Where is the other data come from? Mortality.
Death certificate.
From hospital.
Death certificate.
Yeah, that is government. That is the mortality data, that is the government, right?
ASHA worker can also provide that.
Say again? ASHA workers, yes, okay. That's true. ASHA workers, if they are knowing, yeah, that is possible, but you have to know the.
If somebody is not writing.
Yeah. So it comes from morgues or burial sites, or the coast banks of the rivers, where this burning of bodies occurs. That's where it comes from. They collect the data, by the way. They have that pen and paper, and they write it down, each and every person who is coming with the dead bodies there. So this is how mortality data now start to. Now at that point you have many data set, but the outbreak is over, almost over. So it is not useful for this outbreak, but it is better to understand the future that, or this outbreak to pick up. Okay, so that is this thing is what it is telling you. And again, I forgot to post the slides actually yesterday, but I will do it immediately after this. Remind me actually of slides, the last slides from the last lecture. So I will post this slide, you can see it, what I am writing down here. Now, when it comes to interventions, there are different data sets. What does the intervention mean? Can you name certain interventions in epidemic model? Lockdown is one of it, fine.
Vaccination.
The people who are coming.
Quarantine, yes.
Awareness, vaccination.
Awareness, okay. Educational programs, awareness programs, vaccinations, yes. What else? Social distancing, okay, fine. Social distancing example? What is a social distancing? What is an example? What does the social distancing means?
Interaction is less and
But
large gathering is avoided.
right, so what does government has to do? I mean, what exactly they have to say in order to have a social distancing program?
They
control the
Some
crowd.
restrict.
Control the crowd.
Say it again?
Control the crowd. No?
Control the crowd, okay, yes. So you can allow only, for example, if that's a very good point, very, very good point. For example, when COVID was going on, what they started to do is they left the middle seat vacant in the aircraft. So there are 3 seats, right? So they said nobody will sit. So what did it do? It reduces the density, right? So that's a social distancing method. But there are different ways you can do social distancing, right? That's why I asked him what does social distancing means, right? What other? There's many.
Gathering at the religious.
Yeah, this is all population level. What about at a clinical level, hospital level?
Wearing mask.
Mask, medicines, testing. Testing is the most important one. You know, you do force it to test people. And test doesn't have to be in a clinical setting, it can be in a community setting as well, right? So testing is another data. So what data you have availability? Testing data. There's another data, lab data. For example, there are companies which is only does laboratory work. For example, blood test, saliva test, you name it and there is a test for that, right? They do only those tests. There's a data for that, right? And they are keeping it somewhere. Now, if they are not supposed to disclose unless you buy that data, but this is the data. I want to use only testing data when I am interested in something about test. If it is all about research question also. What exactly you want to address through your epidemic models, right? If I am interested in can a rapid test, what is rapid test by the way? Rapid test. But give me an example. For what? Rapid test is used for what?
Somebody is infected.
But infected of what? Disease. Which disease? Which disease? Well, for rapid test is a quick test. You get a result quickly, right? It is used for flu, for example. It is used for COVID also. And which one is a not rapid test? If they are calling it a rapid test something, there has to be something which is not rapid. What is that not rapid one? PCR test. PCR test takes days, few days. I mean, maybe faster would be few hours. But rapid test takes 30 minutes. It's a machine. So why don't you use rapid test?
Accuracy is not.
Exactly. The test accuracy is not there. And accuracy is measured in sensitivity and specificity. Those are two measures. Sensitivity and specificity measures how incorrectly you are measuring correct cases and not correct cases also. So anyway, I don't want to go in that direction, but this is so this data is very useful if we want to answer can rapid test. Suppose someone discovered when COVID was going on, there was lots of rapid tests coming to the market. And
rapid test, I think, were testing for disease.
Yep. Yeah, it takes some biomarker from your body and find out whether you have an infection or not. Typically, it takes your immune response cells. When there is a certain type of pathogen, your certain types of cells attack those areas, right? So there will be more of those cells. So by that they know that which pathogen is more in your body, basically. That's the idea, right? So rapid test is used, we use the testing data a lot, right? So, but what I'm trying to stress here is the research question from the modeling. The modeling is not only about what is my forecast of number of cases. It answers many other questions. That is what I'm trying to stress about. For example, it can answer a new test that just came out by the company and you want to test, can rapid test really helping or not helping? This question you can answer it using your model. That's what I'm trying to stress upon. So it's a different question than what we were discussing, forecasting and all those other things. The same SIR model with a diagnostic test in it can answer this question. Does that make sense? Okay. Next is vaccine. So you will have S, I and R and then the vaccine compartment, right? And if your question is about, research question is about vaccine, then you would, for example, which age group to give vaccine, right? So these are the questions, and also people evolve over time, right? Things that are working 10 years ago may not work the same way as today. Same vaccine might not work the same way today due to many reasons. So you need to test this vaccine again and again, even though same vaccine you are talking about. Okay, so also travel restriction. You know, you were talking about social distancing. There are many types of social distancing. Who tells the person that this social distancing will work and this social distancing will not work? You do it in a model. You build it, this mechanism of different types of social distancing in the model and track the infection through the SIR model. Okay. So that is what goes in travel. Okay, so these are the so the question is very relevant. What is your research question that you are addressing? Now when you tell me what data is needed, I would not always say I need only number of cases. If you need for prediction, yes, you can use that. But if you are talking about testing, then I think more important is the testing data. You see, so next time when you want to say, ask someone a data, you have to be very specific. You have to be specific based on your research question. Is that making sense? Okay, this is a very, very important point I am trying to make. So data set shift based on question related to not only intervention but research question in general. Running too fast. Okay. Now surveillance system. So case count data. Yesterday we were doing example of a case count data. What is surveillance system, I asked, and you guys were giving me some answers. So let's see what is surveillance system. There are hundreds of surveillance systems. Let's look at what is the surveillance. Now why I am telling this thing? Because each surveillance system will have its own drawback. Okay. So for example, there is a passive surveillance system. What does passive means?
Government says what we are collecting the data.
Correct. Have you heard of this IDSP? IDSP is a government body. It's Integrated Disease Surveillance Program. They do it all the time. Every day it is running through ASHA workers. Right? And it is collecting epidemic prone diseases data. In India, like diarrhea, food poisoning, measles. These are the data that is collected through that. But they do it not because the outbreak is there, but passively, every day. Active, what is active means? It's an opposite of passive. What is active means? Active is you go door to door and ask specifically, do you have this disease? This particular disease. For that you need to do an extra effort. Right? You can't run active program all the time. It requires a lot of resources. So active is only done for a specific projects and time to time. When for COVID, many active surveillance was carried out. Centennial surveillance. How is centennial surveillance carried out?
Where there is a chance of likeness.
Yeah. Typically, selected sites are there, but typically, why is it written? Because it is done typically by the researchers in public health department. They have got a grant to do a certain surveillance of certain things in a certain regions, and they're repeating that thing again and again on that regions. Okay, typically those are the selected sites that they carry out. Event based, like news, social media, mobility data, I gave an example, search trend. I think they are working on a Google Trends data, right? So their project is on Google Trends. What is Google Trends? Can you explain what is Google Trends to?
Much idea about it right now. Like people search on whenever there is some event, people search on the Google, and that data is collected for every event.
Yep.
So we can extract the data from there, and then we call it as Google Trend. That may be a hypothetical data as well.
Correct.
But then with actual data, we can do the comparison and then complete this.
Yeah. So, first of all, Google Trend is a website. It's a website. It's not a real public health data, but it's a signal for people searching different terms. They have for dengue, they have for malaria, they have for obesity, they have for different things. They give you exact data. How many times people search similar terms related to dengue, for example. Does that make sense? So it gives you a proxy. You understand proxy? Not exact data, but something which could have, you can map it to exactly. So it's a proxy data because it's a search data, not a patient data, right? It's a search data that what all of us are searching in the Google, they are keywords they are looking for, and they are plotting different curves. Does that make sense? So suppose when the COVID was occurring, people were asking about mask use, people were asking about diagnostic tests. So there is a different curve they were plotting. You understand? So those are the data that is, sometimes we use it in epidemic model when actual patient data is unavailable. I think some data you can get it free from Google Trends. Google Trends is a website, by the way, Google's website. And when you browse it, you will learn many things from there. Laboratory confirmed, as I was discussing, laboratory confirmed is some of the data set. Genomic surveillance is another thing. There is a genomic databases. Databases means a centralized place where people, when they sequence something, they put the information there. Again, this is a different types of model, but genomics models, but often people use it for modeling purpose. Examples where you will get data is WHO website, CDC is Center for Disease Control, that you can get is ECDC is European website, that's where you can get it. From India, ITSP surveillance data is easily available. Anyone knows what is this? MOHFW?
Ministry of Home and Family Welfare.
Family Welfare. So Ministry of Health and Family, it's a central government institutions, which ministry basically, and where they collect the reporting data for many diseases, not only COVID, but latest disease more often. Google mobility reports are also there, by the way, from where you can get mobility data. Now this is from the Google searches, not from the apps. Apps is a location-based services, which is different. Location-based services is from your cell phone. Okay. NVBDCP, what is that? Have you heard of that? It's National Vector-Borne Diseases. It is National Vector-Borne Diseases. There are many institutions in different places of in India. And malaria, all the vector-borne disease. What is vector-borne disease? Malaria, dengue, chikungunya, leishmaniasis, all is spread by insects, vectors. By the way, that was my research area. My area was, main area was neglected vector-borne diseases. Which are neglected? Malaria is not a neglected disease. Chikungunya is a neglected disease. Leishmaniasis is a neglected disease. Yes. So encephalitis is also a neglected disease. So there are certain diseases which are vector-borne and get neglected for a long period of time. So ICMR, Indian Council of Medical Research. I am a fellow at ICMR, and that has a testing network. Actually, some of the testing data you can get from their website free of cost. So, data on a transmission or incidence. Now, this is very confusing for some of us. Yesterday, Dr. Ghosh was mentioning about incidence and prevalence. Incidence has a time unit. Prevalence could be a time unit, but it is called a different, it's called as a period influence. Different terms we use for prevalence. But if you say prevalence, literally it is proportions, no time units. Okay. Basically, it is new incidence is new cases in a certain period, in a past 1 month, in past 1 week, in past 1 year. Okay. Prevalence is total cases currently divided by total population, or not the population, population at risk. So if there is a childhood disease, you cannot take adult in the denominator. Total should be total children. Okay. Case fatality ratio is also a data that is used, which is death over confirmed cases. What does that mean? Case fatality ratio.
What is the total case and how many of them died?
Exactly. So among the cases, known cases, how many died? Among the known cases, how many died? Right? So that's also data we use. Population data we use, how big is the population, so we take census data, right? We take contact patterns. How do contact patterns, where is contact patterns going in the model? In the beta, right? Sometimes you can find contact patterns and estimate beta directly, and sometimes you can't, right? Depends on a disease. So contact patterns, how do they find contact patterns? How do they find contact patterns? Any guesses?
There are counting cases on daily basis.
But
They are five.
no, so here it is not about disease at all. It's just how people are contacting each other. How do people count?
Buildings,
Huh?
shops, buildings.
What is the problem? If I am in contact with him, or I am in contact with him now. So you have to define it. You have to define what exactly contact means. The definition of the contact. Sorry. So we have to define it what contact means. Typically it is done by surveys. Surveys, how do you surveys? How many friends you have? How often you meet? When do you have parties? All these questions goes, and then from there you extract the information and define based on your definition of distance, and then it's a very, very tedious task, very tedious task. But sometimes you have to find it. That's a research. People do that research. Okay. Okay. Now, behavior data, also location-based services data is used. Location-based services data is used to contact patterns, to know the contact pattern. And Shichand is here or not?
No, he's sleeping.
And say again?
He was sleeping. I knocked his door. He was saying, why Alpha?
He's joined online. Shichand, this online will not work. You will be coming here. He's listening. I don't know if he's listening. So he will be talking about social network tomorrow. So he will be talking about how he is collecting contacts. So that's where we'll see a few interesting features. Now, we talked about this reproduction number yesterday, right? We all are okay with that. And we said this is transmission rate, and D is actually sometimes written as infectious period is easier to, in days, is easier to find from the hospital. And then 1 over that is the duration. I'm sorry, 1 over gamma. Gamma is a rate and D is a duration. Gamma is a rate and D is a duration. Remember that. It's an inverse of each other. Okay, so we know that it is epidemic grows and ends during this time. Now there is another reproduction number which is called effective reproduction number. And basically it's R0, the same R0, and multiplied by number of susceptibles. Why is that so? By the way, what is the meaning of R0? What is the meaning of R0?
How much capacity a person is having to spread the disease? One person,
How many new cases the person is generating? One single case is generating on an average. On an average. That's an R0. Do you think that will remain the same all the time? No, because the pool of susceptibles are changing. Right? If the pool of susceptibles due to interventions have changed to a very small pool, the number of new cases generated must change. And that is what this is saying. This formula is called effective reproduction number. This is, so where do you use R0 then? R0 is used initially when outbreak is exponentially growing. But as soon as exponential takes a turn, it is not exponential anymore, then you should use RT, which is our effective reproduction number. Okay, so change in behavior, sometimes people are afraid. How is behavior changing in the population? People were very afraid of COVID, for example. They were not going out. So that's a change in behavior, right? That changes things, ST, right? Vaccine also changed. You will not go, you will still go out, but you are vaccinated, so you are not part of the susceptible pool, right? So that's where it's changing. When do you decrease, like lockdowns, these things reduces RT, but mobility increases. If more people are coming from outside to this city, then RT will increase. The more susceptible coming, it will increase RT. Right? This metric is used by all over the place. RT is always used by these big organizations to track the disease. How fast it is spreading in the population. This metric is talking about that. Okay. I hope you guys are not bored. Yeah? I can still continue? Okay, so we'll take a break in a few minutes, but I think I'm coming to a very interesting point, and you will see some models and analysis also. So, what are the challenge in data. And again, we were talking about uncertainty, and this is the most important work that statistician and even some mathematicians do. Finding out what are the difficulties with the data. So, underreporting, underassessment are the two terms used. You might think both have a synonymous meaning, but I will show you in the next slide. I don't want to give the definition right now. But it has something to do with not getting reported, right? Delayed reporting, it takes, see, ASHA workers report, then it goes to the sub-regions, regions, districts, state, central. By that time, there's already a delay, right? So that delay is common in any system, right? So that's a delayed reporting. Changes in testing policy. They will say, oh, initially they will say, we will only test people who are showing some symptoms. Then they change the policy 2 weeks later as the disease was progressing. Well, we will randomly test people. Then they say, oh, we will find which are the pockets of population which has larger cases. We will test every day on that population, but rest of the population we will not do. So the policies changes, right? So that testing policy changes based on therefore data collected. Because if you are using testing data, your data will be impacted by the change in policy a lot. Okay, so you have to know how is this data being collected. Missing and inconsistent data, people sometimes make a mistake. Instead of TB, they write BT. Right, it happens. Measurement and reporting bias. Well, we are human beings, we have our own biases, right? They might say, someone reporting the case and say, oh, our community cannot have this disease, and they put 0 in the columns of their community. It is possible. So there is always a bias. So COVID-19 deaths underreported in many. This is very well known fact. We still don't know how many people died from COVID-19. But we as a modeler now know exactly how many people died. It is not by the government data, it is by the modelers that have estimated the number of deaths. Okay, I'll come to the point that in a few minutes. Seroprevalence studies are done as a sentinel site surveillance. For example, seroprevalence, what is seroprevalence? You collect a serum from people. It's a clinical trial studies for different things that you collect the serum. Okay, so why underreporting occurs? Level of testing. Well, today I am testing once a day, then I say twice a day or thrice a day. So the level of testing will clustering, super spreader. Have you heard of super spreader? In COVID, it was happening a lot. Some people, in fact, exactly. There was one woman in Singapore that infected. There was towers of apartments of 100 floors. She infected 250 people in that apartment complex. Just single woman. Whereas R naught for reproduction of R naught for COVID was 1 point something, 1.7, or some places were 2 also. Which means one person on an average infect 2 people, whereas that woman infected, older woman infected 250 people. Because she was distributing, she was cooking at home and distributing something in different floors. Okay, so there are super spreaders in the community that could alter the data. Right? So you have to know characteristic of the disease also. How does that spread? Policy, of course, we use hospital data, for example, many times, and it depends on seasonality. Flu are more common than in certain seasons, for example. So you will have more cases and you will have better data. But if it is not a seasonal season, people may not come to the hospital. So that data fluctuates quite drastically. Sensitivity and specificity of a given test. Okay, so let's talk about under-reporting and under-assertment and underestimation. These are commonly used words, and public health officials chew every word very carefully. It is not randomly. Even mathematicians do it, but only for mathematical theorems and mathematical symbols. They design the word in a specific way, which has a specific meaning. As I was telling you yesterday, estimation, calibration, inverse problem, regulation, these are often used. People understand it in a similar way, but they have a very distinct meaning by mathematicians. Okay, so I don't know if you can see at the back this triangle here. What does it says here at the bottom? All infections, symptomatic and asymptomatic. Asymptomatic means people not showing symptoms. So it's an all infection. What is this? All symptomatic infection. Right? So under-assertment is all symptomatic. So people who don't get, so asymptomatic, if you remove asymptomatic, that's an under-assertment. Because asymptomatic are the cases also, right, of the diseases. If you do not count them, that is an under-assertment. Okay, and under-reporting is, those are symptomatic, what is it saying? Correctly diagnosed. They are not correctly diagnosed. Because test also has some error. Right? You test it by instrument and they fail sometimes. So if that happens, then it is called under-reporting. You see, the terms are very different. Right? And then comes cases who do not report. Right? Is that making sense or no? Who do not report, that is called underestimation. Okay, so these are three different terms used in a very different ways. Now the question is, what should I do with this? Well, you have to build it in the model. And how do you build it? That's the challenge. So first of all, you all understand these three different terms, right? What is first one? Under-assertment. And what is that? No asymptoms.
Asymptomatic.
Yeah. So basically, no symptoms. Right? People are not in. If you miss people not showing symptoms, then it is called as under-assertment. Under-reporting are people who are test error, not correctly reported. Right? They are there for reporting, but they are incorrectly measured, either by the test or by the human error. Okay. And the third one is people are not going for reporting. Right? So they are not reported to the authorities who are collecting the data. So underestimation is that. So let's see how we model this one. So this is a model that we worked in Bihar. Bihar is for leishmaniasis. And this is a work done in 2010. So at that time, it's called State Society of Bihar or something like that, State Health Society of Bihar. This is the health ministry of Bihar, basically, state government. They did not know how many cases of leishmaniasis are there, because there was so much problem with their surveillance system down the line. I mean, still there is, but at least now they have a method that we have provided a tool that they can capture using the reported data. So what was happening? There were lots of people going to the government doctors. People are getting reported, but they were getting to the government hospital. There are some, private. T is a patient's, how did I go? Healthcare, so not accessing reporting agencies. That means the private sector were not part of their surveillance, first of all. There are lots of, so lot of people in India goes to private sector, right or no? So if you use the government data, now government data is trying to capture the private institution a lot, but 2010 this was not the case. So so that's why the model built two compartment of treatment, one which is government and the one which is non-government, which is T, private sector. And so, so what is S? Susceptible. What is A? Right. People not showing symptoms. I, people are infectious and showing symptoms, but they are treated, G is treated in the government facility and T is treated. They have to get treated, by the way, otherwise they die at that time. The patients were so bad infected that they would die from that. So they were getting treatment either at government or at private facilities and recovered. So this was the, and some asymptomatic folks were directly recovering. So is the flow chart clear, everyone? This is how we build the models, right? So now, this reproduction number consists of two parts. If beta is for A and I, A is people not showing symptoms will typically have less rate of transmission, right? And people who will be infectious, their infection level is very high, so they will infect more, right? So these are the two parameters for each one of the compartment, A and I. So R naught is, what is R naught? Yeah, it's initial, but what is it capturing?
Infected person spreading.
Yeah, average infected person, average infectious person infecting others. So these are two infected people because these are in treatment. They are isolated from the rest of the people, right? These are the two infected class that could infect in the population because they are circulating in the population, right? So they are infecting less and they are infecting more, but both are infecting. So R naught is an average of people infected by A compartment on an average, and this is a term for I compartment. So it's a sum of those two average infection that a typical infected individual in that community will infect. Does that make sense? Now note one thing. What is 1 minus Q? See, proportion of people that are going this way and not going this way, because if they go this way, they will not infect. Right? So 1 minus Q are the people goes there. So the person in the A compartment infect and then leave this way. Those people who leave this direction will going to infect this way. Is that making sense? So this is capturing fraction of people who doesn't go this way and go this way. Right? This is capturing this term. So the R naught is basically the sum of these two. On an average, how many this person and how many this person does. It's a sum of that. Does that make sense? Yes, no? Yeah. So it's a easy. And how do we calculate R naught? The same as the next generation operators that we showed in the epidemic modeling class. Okay? So once we have this thing, okay, so now where is the underreporting here and underassessment? Where is underreporting? What was underassessment?
I said
Right. So which one are the one you will not get to know? People, well, asymptomatic are not showing the infection, so you don't know they have it.
That population is P.
So these are the people who are under assessment. Q is a fraction of people that they will recover by themselves and you will never know that they are infected. And 1 minus Q is underreported. Underreported is they are not getting treated reported in the government facility. You see how beautifully we captured it in the epidemic model. It's so strong. This is so powerful, this method of SIR, that it can capture testing, it can capture data challenge, it can capture intervention very easily, these models. But this is one example where you are capturing the data challenge, which is under-reporting and under-assessment. Okay, and then basically this is the main point here that you are capturing. Everyone okay? And what is getting reported? What is the data? Where is the data? Where is the data coming from this model? Government. But where is the data? The rate. So what do you get the data? Data is always incidence data. Prevalence data is very difficult to get. You don't know how many cases are there for a particular disease today. It's impossible, literally impossible to find for any disease, literally. Incidence you can know. Why? Because incidence reporting happens when they show up in a hospital. The new cases that are getting reported. So you can estimate the new cases, right? And this is the rate. This is the rate of change from I to G, right? Every time unit, how many moving from I to G compartment? And that is the data. This is the reported incidence. Okay. So you use this data to estimate your different beta, different parameter under reporting and reporting. Does that make sense? Okay. So this is the study that is published in 2010, and I don't know if you can see it. This is the district of Bihar, different districts of Bihar, and this is the proportion of under-reporting for the year of 2003 and 2005. So we are talking about 2 decades old work. So this is talking about in 2002 and 2003 using the models, and they were amazed. We talked to physicians who was a chief medical officer of the state, and he was amazed to find these estimates at that time. And we made this model as a tool for them to calculate every year after our published work. So if you see these folks, Dr. Pradeep Das was the chief medical officer there in 2010, and he was some regional directors of these last two of them. I don't know if they are still there or they retired, but they were the main folks. So we worked with collaborators, practitioners, real practitioners in the field to work with us. Now this also, I'm trying to tell you how you work with the physician. You have to incorporate them in your own work. This is very, very important because they don't know you. You have to gain trust, right? And it happens slowly and slowly. So I don't know if you can read, there is like around 70% under reporting. So you know only 30% of the cases by surveillance system. That means whatever policy you will make will fail, definitely fail. Because most of the people you don't know where they are. Does that make sense? So this is a very powerful tools, SIR type models to use in this work. Okay, so let's take a break and then I'll continue with this, and then I will take another. Do we have what time is the tea, by the way? It's there. Okay, so let's take a break. I will do 15 minutes more, and then Ashwani will take over from there. Okay, thank you. Tea. Oh, wow. Yes, I don't know about hair, but to give you an example. So this is a mortality data, and it is actually capturing burial sites. There are burial sites during COVID time. They were using in Indonesia to capture under-reporting. Yeah. So somewhere, even a person must die, they have to be somewhere, either buried under the ground or the burned, right? So those are the things that they were capturing. to get a count of mortality. So you have to have some information from a real life, right, in order to model to capture the disease outbreak. And that's what is a very good example. So, for example, they record 3,000 burials a month in Indonesia in some cemeteries, and accounting for roughly, but their cases were not getting reported at all in that town. But that one cemetery was reporting 3,000 burials. So, also what we already know, if there is no outbreak with a major mortality, then there is a regular use of mortuaries, right? There are certain numbers of dead bodies come, which is on an average. They know. Every year they know. But if something increases beyond a traditional standard, then that is what is called as an excess mortality. The word excess mortality is used. And that is the data is assumed to be outbreak related, especially in COVID times. So that is what they were using to track case count. Okay, so you see, by hook and crook, you have to find some information that is real life information that you can use in the model. So excess at least 45. So excess means something which is beyond the standard that they were observing in that cemeteries before an outbreak. So they compare it with the last year, for example. Okay, and then they map it out. So this is the one of the studies that use something like that. Now there is something called as a real world data. Surveillance data also is part of it. The surveillance data that we talk about. But real world data consists of much more than that. So what is the real world data? Electronic medical records, which Sheechal will be talking about tomorrow also. So it comes from hospital settings. There is insurance claim. Why is insurance claim helpful in the disease? What does it give you? Health insurance. Health insurance we are talking about, right? Because what happens in health insurance? You buy some drugs, right? Or you go to the hospital for some checkup and you get reimbursed from the insurance, right? Now, not everyone is under insurance. I mean, many are, because government has a free insurance also, right? They track this. So that has cost of the services, medical services that you have taken, right? So it tracks infection. I mean, it's tracking the basically what drug you will not give it randomly, right? It will be for a specific disease, and therefore the data is extracted from an health insurance also. But it's very difficult to get it. In US, there is companies that collect this data from private insurance companies by paying them. So these are primarily, these two data are, you have to pay money to get access to that. It's not easily available. But this has a rich source of information about infection. That's what and mobility and mobile data. Mobile is a location-based services, that phone data that we were talking about. So where are these things helpful? Estimate the disease burden. It is used for estimating how many cases are happening. It is also used for interventions, how badly or how good the interventions are doing. It is also do the cost effectiveness. So I remember I was telling you a drug which is costing $3.7 million, one dose, but it is cost effective. That means clinical benefit. That means you save the life of a person versus the cost of the drug. To balance that thing, it is how expensive that you can value your life. Does that make sense?
Yes.
So that's a cost effectiveness modeling that we do, where there is a model for the disease spread, then there is a model of intervention, and then there is a model of economics on top of it. So there's 3 layers of models interacting with each other. I think Shichand will be talking about at least 2 layers tomorrow's model, basically. So interventions and disease. So you capture the disease, then you capture the interventions, then you capture the economics.
Yeah.
There is another model on top of it that is a behavior aspect or psychological aspects. That is because you see people, somehow some drugs are easily accepted by the population. Some drugs are not accepted as easily, even though they have a good clinical impact due to many variety of reasons, maybe cultural norms. People were not taking vaccine because their culture was not allowing it, for example, even though some vaccines have a greater impact. So there are lots of issues that comes, and then Shichand will also talk about social network, which is how people interact with each other and move around. And so that's a primer layer. Then comes a disease layer. Then comes an economic layer. Then comes a behavior layer. And then there is on top of it there is an evolutionary layer, which talks about evolution of strains. So depending on your research question, you mix and match many of these layers of the models. Okay. So anyway, so that's something to and how many of you know what is randomized data? What is randomized data? Have you heard of clinical trials?
Yes.
What is clinical trials?
Giving some drugs or something to two different groups and analyzing it,
Yeah.
whether it's
But why is that a real world data? No, it is not a real world data. Why? Because it is under constrained situation. It's in one hospital, people have to do certain way, they will get injection. In real world, you will not get a treatment sometimes, right? Real world is general situation, real world. So this data, which is not a clinical data, is referred as RWD. And any information that you extract from it is called as real world evidence. Okay, and these are all real world data that is we use in the model. Okay. So we use real world data to estimate. We already talked about it yesterday. Exponential growth, right?
Yeah.
And then from there you calculate reproduction number. From there you calculate beta, and then basically you can capture the epidemic. Okay, so
Oh no.
yeah. So what are we using data for in the model? We are using data for calibration or fitting the model to get an inputs of the model. We are using data for validation. We are using data for doing sensitivity analysis. What data is different in sensitivity analysis? What data is different in sensitivity analysis as compared to these two data? The ranges, confidence interval, exactly. Right? Here you can find a point estimate and that is more than sufficient. And even in validation also. But probably for sensitivity analysis you need a range. Scenario analysis is also a different type of analysis. It tells you what if situation. What if I have infinite amount of dollars? You know, typically not. But you can run the worst case scenario. You can run the best case scenario. You can kill people in the model, right? So those are scenarios. Typically done for policy evaluation or intervention. Some of you are doing evaluation analysis in modeling from your research group project. The scenario analysis is must in that type of project. So SIR, SEIR model predict demand, how many cases will be there, that will help you allocate resources, how many doctors are needed, how many beds are needed, this is what we did. the model. Mobility data will tell you how the policies are working or not working, right? You can compare with the prior to the implementing the policy mobility data and after implementing a mobility intervention, and you can compare. That will tell you the impact of that. Vaccination data is also used for strategy prioritizations. So these are the general things that that is helpful for you in the modeling, and I think that is all I have for this data. I hope it gives you a picture of the way we use data in different ways, and it is not that easy. When we need a data, we have to be very careful what we are asking for. We can't just say that we need a data, right, from someone. Okay, so I'll stop here. Thank you. So the next is, I think, Dr. Jayaprakash is there. So there will be next talk is, instead of Ashwini, I think we are having Dr. Jayaprakash, and he will be talking about some interesting stuff. Those two folks